Welcome to another episode of The Disruptors, where we're arming you with the tools you need to innovate within the physical therapy space by highlighting those who have come before you. I'm your host, Stephen Cohen. Now, let's get into it. All right, everybody, welcome back to another episode of The Disruptors, where we're highlighting innovators within the PT industry. Today, I'm blessed to be joined by Daniel Vapne. Daniel, would you please intro yourself for those that somehow don't know you?
Yeah, sure. So, Stephen, thanks for having me on. So my career started prior to PT school. I was working in private practices and overseas. I graduated from physical therapy school in 2019. I did a residency to get really good in orthopedics. During my residency, I was blessed to have a lot of mentors, and I learned marketing, sales, like how to operate a business, like how to do that. I opened up a de novo clinic sort of during COVID. All right, they opened it up right when COVID started, and no one came. Right, so I took over like a year later, and I made that practice grow from scratch. And then I moved to the Northeast, and with that larger organization, I was able to expand our Northeast footprint. My wife didn't want to move, and so I partnered up with a friend that bought a private practice during COVID from the previous owner, who is still with us. And I started looking at their contracts and everything. I was just like, what is going on? I came from this large entity that was getting paid like $400, $700 a visit to now this small clinic's getting 50. And I was like, the math isn't mathing. The service hasn't changed. I still provide the same service. What's going on? And then during this past year, I feel like it's been longer, but the last year and a half, I've been growing this practice in Long Island, New York. I've been publishing research with some faculty members at Hofstra with Kenotech, and I was an adjunct professor at my alma mater, which has become Toro University, and now I'm creating 3 vehicles to increase reimbursement for private practices. One is a MSO model, one is an IPA model, and one is an ACO model, which I figured out private practices would rather negotiate and spend resources with larger players than small mom and pops all across the entire country.
There's so much to dive into. I'm incredibly excited, and yeah, from graduating in 19 to now, you've been busy to say the least. Before we dive into a few of those pieces that you're working on today, would love to get an understanding of why PT for you, right? Like, why did you choose physical therapy as a career?
Yeah. Like many others, it kind of fell into my lap. I didn't get hurt right away. I was interning at a physical therapy clinic before college, and I just liked the environment. It was transformative, right? So like, this is a place where people went and they came with the mindset, I need to get better. And these are the people, and this is the place where I feel comfortable doing it, right? It's kind of evolved from there. I always wondered, like, why do people get hurt? And why is it that some people get hurt more often than others, right? Yep. So I've been diving down like these questions of like, what does it mean to be more fragile or resilient? And I've learned a lot through PT school, through residency, and mostly through my patients. But I felt like this is one of the fields, like every field is like, helps you with something. And you go to an accountant if you need help with your taxes and figuring out like how much money I made and how much I lost. You go to a physical therapist when you can't figure out your own body and how you're moving and what's happening here and why do I keep getting hurt, or how can I be more efficient, or how can I walk again, right? Or if you're a kid, how can I start walking?
Yeah.
So there's so much we do, and that's why it's so hard to define our profession because we are literally doing anything that involves you moving your body or you performing the way you want to perform. And if you feel like you should be able to do it at a higher level, be more efficient at it, not get as tired, we touch that area.
Well, and we've seen that just in our own client base, right? Like even in the same clinic, you might see a vestibular patient and a pediatric ACL repair, right? Like it, and there's a pretty wide swath, right, between those two individuals, and so yeah, I can appreciate that, and like how you found it through. You say it fell into your lap, but I'd imagine it took some, you know, interning before college is that's a good move. That's a good move on your end. Not something that I did necessarily. My I guess my interning was out in the oil fields of southeast Kansas and running a pulling rig, pulling
There
unit.
you go.
Yeah, that learned a lot there. Heck of a lot. Including how to put together a lot of four-letter words in very creative ways. But so that's why you got into PT. That is, I love that story. And walk me through. So you've got these three vehicles you've created, right? I know that you and I have talked about
In process.
in process.
Two of
Sorry.
them are like in process, but yeah, one is a little bit more refined than the others right now.
Fair enough, right? So these three vehicles that are in flight, right? They are moving forward, and help connect the dots for folks, and both from like a historical, so they can get to know you a little bit better, but also from like your thought process, right? So the goal of this is to be able to help people feel like they got one or two tactical, tangible pieces of insight and advice to help make their own innovation journey that much easier. So walk me through from wherever you want to start between where we left off and where you are today. Like, what did you recognize? What did you do? Right. And maybe even like a little bit of what you would do differently to go from there to today.
Yeah. So I joined my friend at his private practice, and I started looking at the numbers, right? Like how much should we get per visit? Like the things that a usual operator looks at. What's like our payer mix, this and that. And I started looking, and I was just like, what is going on here? Like how is it that one payer is paying us $50 a visit, and then with someone else seeing them, they're getting paid $59 a visit just by who signs the note, right? And then, right, so depending on when the contract happened, when the credentialing happened, and then I started diving deeper. It's like, all right, let me try to move this up. No one's talked to someone from the payer side in years, maybe decades.
Yep.
And
Yep.
so, and so some pairs, you can get to a person and they make it hard. Like you send an email, you have to go to the secure portal. Getting into that portal is very hard because you have to use a secure link. And like, there's a lot of friction there. I don't know if it's on purpose or this or that, but like, there is a lot of friction with dealing with these larger entity groups that, pay us for serving their members. So I was in the process of doing that. I was able to negotiate as a small practice with one payer through their like third party administrator, which was they wouldn't go directly to me. I had to go through a third party. And another payer said, no, our network's closed. Try back in 3 months. And I was just like, what do you mean? I'm seeing your patients now in my clinic with one of my therapists. Why can't you just add me in? And they're like, no, our network's closed. I was like, so I tried again in 3 months, and guess what? The network is still closed, buddy. And then I tried again, and I was just like, this is awful. So I couldn't even get in. So someone had to co-sign my notes until I met an MSO that started out and in the dietitian space, and that MSO is in New York and New Jersey, and that's called a ZiaCare. And I met them, and they didn't realize like what they had. Like they're like, we're focusing on dietetics first, and we have all these other groups, but we're really trying to focus on that first. And I'm just like, what's the biggest problem that they have? And she said, well, like they like only 1% of people that have insurance really use dietitians. Like it's not utilized. And I'm just like, so you have these physical therapist contracts and you have like one or two practices, but they're not even sending you referrals to the dietitians. Why don't we get private practices in? We don't have a problem getting patients, especially if the private practice has been around for over 3 years. That's not physical. That's not physical therapist problem. Our problem is our X per visit. There's only so many people that we can see per day. We need our X to go up. Like we could have 10% cancellations and our margins are small. Like we need our value, our reimbursement per visit to go up so we can pay our people to keep up with inflation. We can pay so that when new people come into the field, that they can pay down their loans. It all comes back to that. Like it all, like to me, that is value. And I've always been like, who dictates that? And why is it when I move from one entity to another entity, the payer values me differently, but I'm still giving the same service? So I linked up with this MSO and we started creating a PT product that is a wraparound, because every practice is different. Like they use different EMRs, right? They have different processes. How can we make it to streamline, to decrease their admin work with verifications, authorizations? Because the billing process starts before the patient walks in through the door, right? You need to make sure you can see that patient, right? That they have benefits, that like the premiums that they're paying every month can actually be utilized by you. And so they do that. And then once we see them, do the billing process through them, and then get reimbursed back to us. So we created a product in like end of April, May. We launched several practices. All right. There's, whenever you launch like a prototype, there's some bumps in the road. Now we're trying to integrate with more EMRs where, all right, like you get it in and it comes in and it like auto posts and it's more automated, right? The less people that needs to touch the process, the better. Like, you know this from your work, like, you know, in like consulting, management consulting, make things streamline and automate so that you can be more productive with your people. Because in this day and age, our people are our most expensive resource, and we need to make sure that they don't get burnt out by doing tedious work, and that they feel fulfilled in the work that they do and they feel compensated, right? And so that's kind of what we created there. So that's one vehicle, the MSO. So it's a multi-specialty organization. So what I found out, payers like to have things grouped together. So if you can have dietitians, physical therapists, occupational therapists, speech language pathologists, maybe midwives, maybe an MD in there, there's a premium there for having that all under one roof. That's more ICD-10 codes. That's more claim volume, which payers like. If you have more claim volume, it means you're servicing a lot more members. That means you have a bigger footprint. So we're going to incentivize that. So in that fee for service model, that's incentivized. So that's about the MSO route. Like the members don't have equity there, but in the IPA way, everyone's a shareholder of the IPA. And that's a little bit more complicated when you have everyone have an equal say, right? So that's why that one's not in flight yet. But we're trying to figure out, all right, is it going to work? And we have a lot of people that like this. So we created this nonprofit IPA in New York. It's called the Private Practice Network IPA, and we wanted it to be nonprofit and be our like pass-through so that these large payers can talk to all these small practices under one umbrella as well. Still figuring out how to make everything work. It's not as established as the MSO was, right? They got credentialing under wraps, they got billing under wraps, they got verification checks. Like they built it out, and now it's just scaling there. The IPA, we're still figuring it out from the ground up. And so the difference there is there has to be some uniformity there. And that's very hard to do, especially when you're a private practice owner and you've done things a certain way. And Jim and Bob down the road have done it their way, right? So it's hard to get everyone doing things, the same way and systemize everyone. So that's the other side there. And then there's the ACO route, where it's an accountable care organization, and payers like that because you're sharing risk there. You're sharing their risk. And so they might give you like a fixed sum per year based on the past 3 years, right? And like every year you'll try to save costs here. It's all about like percentages, and depending on claims volume, it might like increase, right? And here you have to work with like primary care physicians a lot more, because right now all the value-based care stuff centers around them. All right. So when you work with them, it's like, all right, how are you going to reduce total cost of care? And we know musculoskeletal injuries is like most of healthcare, right? It's like 60% of utilization is MSK injuries. And physical therapists is only like 5% of the whole like healthcare spend. I think it's like PTOT is like 5%, right? So if we know that, all right, even with all we're doing, we're 5% of spend, and imaging and surgeries and procedures and drugs are a lot more, maybe we can actually decrease that. And so the APTA has done a phenomenal job the last several years in their policy and what they're pushing out. One of the best things they've done is actually having that economic impact study, right? Like actually showing costs, right? And our value. And payers see that, but they don't know what to do with it. Using an accountable care organization to say like, hey, we actually can save money here, and this is how much on average. And this has all been done by an independent actuary group. And they're like, okay, maybe let's trial this out. So that's the next vehicle, is saying like, all right, let's do this on a larger scale, because if we only have a little micro system here, it's very hard to show like if it works. But if we can have Dan's practice and like 100 other practices doing this, and maybe we can actually, show that we're providing more value, especially with those like Medicare Advantage plans, where like a lot of that is going through that value-based care right now. And we're going to see how that happens. It's like a little experiment for the next 5 years.
Let's start at the back and work our way, I guess, or whatever, the last piece and work our way back. The ACO is just really, really interesting. I think the focus on Medicare Advantage plans makes a ton of sense, given that a Medicare Advantage plan makes the most money when they can manage a sick person, the sickest people well, right? Like that's when they have that RAF score, right? What is the risk adjustment factor? I'm not sure but that RAF score, like when that can be really high, but cost can be really low, that's like golden. And you luckily you don't have to look hard, right? What is it? The Bellin Hospital did this, as well as the VA with military, in having PT as a conjunction with primary care. Like you don't have to you don't have to look far, and you're able to see where these models really, really work well. So I think while a longer burn, right, on the ACO front, I think there's so much opportunity there. Thank you for listening to this episode. This would not be possible without the sponsorship of Sarah Health. Sarah is the relationship operating system for physical therapy practices, driving better patient outcomes, improved arrival rate, and improved financial margins. If you'd like to learn more, check them out at Sarah, S-A-R-A health.com, sarahhealth.com. And if you'd be interested in advertising with us and helping us produce even more great stories, please let us know at steven@sarahhealth.com. Now, back to the episode. I think we talked about this, but and I'll put it out there. My next business idea, right, is PTs being the ones who run the health risk assessments with like an NP or MD on call, right? Because then like, hey, like United, right? You're paying Signify Health $300 for this health risk assessment. Okay, pay us the same $300, and you get a movement assessment out of it. But all the same data. You probably actually get more, because I would argue that based on my interactions with MDs and NPs and PTs, that PTs are generally better at getting the context and social determinants of health. Part of that is the system in which they both operate, right? Like you have typically 30 to 60 minutes with a patient. Primary care might have 3, right? It's not purely a skill set, right? It's a bit of the system. So like, not disparaging any of my doctor or NP friends, including my wife, who's a family nurse practitioner. So I think I'd be very careful there. The IPA, that it almost sounds like a little bit of a B Corp, right? And thinking of it that way, like, you're doing it through the nonprofit, but the idea that you can give ownership in a larger entity, right? I think that's very cool. And the MSO with Ziacare, I mean, that makes so much sense. All that makes so much sense to me. And what I want to come back to is where you get the energy to do these things. So if I'm reading between the tea leaves here, and maybe there's something that happened in child, I'm not a that type of therapist, but maybe something happened in childhood or something else. Like I feel a very like Robin Hood persona coming from you in like the most positive sense, right? Of like, hey, you see these payment inadequacies to providers, and you want to go fix it, both from the practice owner, I heard you talk about that, but also from the staff therapist perspective. Like you shouldn't be coming out of school with $300,000 in debt and only be getting paid $75,000. Like that's not realistic, right? Like if any business school in the US had that as their, probably in the world, right? If any MBA program was like, hey, guess what? Like, here's the deal. I'm like, no, like absolutely not. Like hard pass. Now, granted, you could argue that you're not doing something as edifying as taking care of people. Typically, post MBA, and I would absolutely say that in my experience that is true. But asking people to do that is not sustainable. It's not sustainable. Yeah, I'd be curious your reaction to my Robin Hood comment.
No, it's you're right. Like I feel like we're here because of just being not vocal and not active in policy, not active with and telling our like patients like what's going on, not being transparent. I'm sure this exists in other professions too, but we've done a really bad job as a profession telling our peers in healthcare what we can do, right? And so on that side, and they're the ones, the MDs are the ones creating most of the policies. Like the AMA is huge, right? The AHA is even bigger, right? So if no one knows what we can do, and like everyone does PT, but they don't realize that PT is not valued so high. But if you look at like all the other countries that have something similar to us, like the physios and stuff, they're valued so high, and their health outcomes are way better. And I'm not saying just physical therapy can increase health outcomes. I'm just saying, like, if physical therapists are utilized effectively, we can actually bring people from the bottom up. If we triage first, and because of how much time we spend in the relationships we provide, we can send people to the right provider, right? And for the right interventions or more right intervention, then we like imagine a surgeon that has to see like his whole schedule is filled with probable surgeries rather than possible surgeries,
Yeah.
right? That will make their lives so much happier. Or the orthopedist that knows like I can inject like 85% of my schedule versus like 35%, right? And it's efficacious. So I'm not saying there wasn't waste in the 90s, in the early 2000s, and I'm sure it was overutilized, and I'm sure the payers have good reason to do what they're doing. But I feel like we're an underutilized resource, and I'm not saying as a whole, like now there's not enough physical therapists because of how the system operates, and there's not an incentive for more physical therapists to stay in the field and be clinical because we tap out. Like right now, I'm seeing so many physical therapists at technology companies, at sales companies, at this and that. Like they're out of the field in like 3 to 5 years. So like I think Larry Benz published an article that says of the ones that could work and see people clinically, I think only 20% are. And I don't know where he got those numbers, but think about that. Like we have such a huge problem in the United States of access to care. And we have these networks closed for physical therapists to even join them because probably their roster has someone from pre-COVID that hasn't touched a life still on them. And you can't even see their patients. And it's just wild. And I think from a young age, I've just seen like how ideally things should be, and just I've never taken no as an option. I've always found a yes. Like I've I haven't, like both of my parents are immigrants. I had to figure out how to get what I needed in order to thrive, and so you figure it out. Like you do that. And so what now? And in my 1.5 years of being an owner, I want to pay my employees as much as I possibly can. And I want to keep up with inflation. And I want to, like, my biggest thing is how happy, my biggest KPI is how happy and how purposeful can I make my employees feel, right? I think you were at the private practice section conference. There was an awesome keynote speaker. Can you make your employees feel purpose so that they can make the patients and everyone that they serve feel more purpose, right? Because those people that do not have purpose have more mental health problems in their life where they are struggling through that. And if in physical therapy, that's our whole job, is to have people perform the way they want to perform. Like they're spending their most valuable resource with us, and that's time. And they're spending 3 hours a week, like sometimes like two times a week, sometimes like one time. But that's time is so hard, especially in this day and age where things are just taking up more time. There's more things to do. They're spending time with us, and that's huge. And we should be compensated so that people would stay in the field and treat, because everyone loves being a clinician. They just hate that there's no room and there's a cap there. There's this glass ceiling because reimbursement keeps going down. And if it doesn't keep up with inflation, we're going to have actually less skilled people here that can actually make a difference in everyone's life. And physical therapy still is going to be utilized, but you're just not going to be able to find one.
Yeah. That is a scary potential future that I want to do everything in my power to prevent. Because and I agree with you. Like at some point, right? Like it's just going to erode, and it's a bit like the story of the frog in the water, right? Like keep turning up the heat. Like at some point, it becomes frog stew, right? And that's it. I want to shift into my next question. And so I don't want to assume. I think I know the answer to this, but I want to assume what your proudest PT, so your proudest career achievement has been to date.
It hasn't happened yet. It has happened. So on the micro level, right? So from like clinician to a patient, like the amount of lives I've changed and seeing like kids take their first steps that were like 8 months delayed, 9 months delayed, and then 3 to 4 is it's you get them walking. Like that's awesome that you can share that moment with like another family.
Yeah.
Getting a stroke patient who hasn't been able to get down to the floor and feel comfortable or confident to get back up in 2 years to do burpees, like incredible that he can do like 8 in a minute now versus 2 years ago, the fear of getting on his hands and knees. Getting someone who couldn't be intimate with his wife because he had pain in his private area, right? And he just got married and this and that, and he couldn't do that. And it was ruining that moment in his life that's supposed to be so special and wanting to have kids and stuff, and helping him through that in like 3 to 4 weeks to where like he feels confident and he's got that, little jump in his step that like pip in his step. Like that is huge, right? And just like creating just an impact on all those lives are great. I feel like I've started accomplishing and improving the reimbursement rate for practices in New York with certain payers, but my work isn't done yet. And I feel like once I can get that average visit with commercial payers to at least CMS rates for everyone, so that practices can actually take people in network and actually stay like open. Because in New York, like especially in the downstate region, there's so many out of network practices because they cannot pay their people, pay their rent, pay everything if they took insurance. Like how, and your insurance goes up every year. It's like another tax. Like it's, if we count since like 2008, when like it's mandatory to have health insurance, if we count health insurance as another tax, we are the highest tax society. I think I saw that from my previous mentor, Zach Walston, where he like showed like, oh yeah, like if we just have health insurance as a tax, it's a mandatory tax going to public companies that are traded on the S&P 500. And if you look at their earnings, right, since 2008, where everything happened and it was just like, everyone gets health insurance, which I think is great. I think everyone should have some sort of insurance policy so they don't go into debt and they feel like it's not this burden, but it still is. Now you have this premium that you have to pay, and then a lot of us have a deductible we have to pay even to access our benefits, and then we have a max out of pocket on top of it. So we have a tax to have health insurance, and then we have these we can't even use it until we pay an additional like $5,000. I'm just like, when does that stop? That's crazy.
And I'm looking at my bookshelf. I don't see it immediately, but next time we're together, if you don't read it before then, I'll bring it to you. It's Dave Chase and with Rosetta Health, and the CEO's guide. I think it's the CEO's guide to fixing healthcare. I think that might be it. But he goes into all of that, and yes, he does call it like the silent gutting of the middle class occurred through the way that healthcare has been mandated and monetized. And he even goes in like, hey, if you're above 500 employees, there's like an 80% chance you're on a self-insured employer plan, which means basically the United, whoever you're choosing, is just acting as an administrator. And they typically take a percent off the top. And so they are highly incentivized to actually see reimbursement go through the roof. Like they'd have no issues paying $500 for an eval at Johns Hopkins, right? Like, okay, then we actually make more money on that. So all that's fine and dandy for us. And that realization was pretty eye-opening, and that's on the commercial side. On the work comp side, learning about the structure of shared savings contracts was also quite enlightening.
Hmm.
Albeit we are a beneficiary of it in a way for a lot of these TPAs that cover remote therapeutic monitoring, the RTM codes, and pay pretty well for it. Now, I would
Hmm.
argue, based on the data that we've seen, that it's a really good investment. Like if you can get that much better of a clinical outcome, right, and your failure to progress like drops off a cliff, okay, then the likelihood that they're going to stay on, like that employee is going to need to be out for a longer period of time than expected, is low. There's some good research around if an employee feels more cared about when they get injured, that they're less
Hmm.
likely to litigate in any way, shape, or form. And so,
Hmm.
gosh, if we know anything, it's that patients do like the check-ins. They appreciate it quite a bit. So can we say that we're reducing work comp lawsuits? No, I don't think we can today. Could we say logically it's not crazy to think it could happen? Yeah, I feel pretty comfortable with adding a little bit more softness in there. But you're entirely right. It is a massive, almost invisible tax that you're not thinking about because it's not on your, it's in a separate part of your pay stub, right? You're like, oh,
Hmm.
I have to have that. Um, but then,
Also,
yeah,
I'm going to add, you said employers of 500, but what about the ones below that? They get also like, cut too. So you're seeing these small businesses actually hit even harder too,
yes,
because they can't self-insure, right?
yep,
And they can't invest in that type of infrastructure too. So they might have to go into these PEO plans or this and that, and those go up every year also.
yep,
And that cuts them. So if you're trying to grow to over 50 employees, it's tough. And then once you hit 50 employees, you have to have health insurance and you have to do this. And that's how am I going to pay my people more if I have to have all these other guidelines and stuff there? So that makes it really hard. But I'll also add, remember when Berkshire Hathaway and Amazon
oh
and I
yeah,
think it was Chase,
yeah,
like
JP Morgan
J,
Chase, yep,
they were going to try to tackle this, right? And I think they like gave up, but they had some valuable insights there, right? And their biggest insight is when you actually get healthcare like what was like in-house healthcare, right? You can actually decrease the cost. So if we actually have like a doctor on staff, right? So if we were big enough, like Barclays or JP Morgan, to have like an in-house doctor, if anyone
yep,
needs it, just could go in. There's no barrier of entry. You see them. That if you have a PT like in-house, like if you're like a factory worker, and there's a PT or an OT there, right? Shout out to my OTs. They do great work and they're awesome in that in that environment. They're really great. They educate, but that actually brings costs down for healthcare spending, and so their self-insurance starts making sense there,
yep,
right? Where because they have an employee, just like a legal team is in-house,
yep,
right? It's a lot cheaper than outsourcing it. Now you have your PT, your doctor in-house, where they can triage you, give you reassurance, educate you, and start telling you exactly what you need to do to like not miss work, right? So all of that stuff can actually decrease everything because it's all done there on site,
yep.
or that they can check in with remote therapeutic monitoring after that to make sure that they can continue to come back to work, because the people that are out longer, it's a way harder to get them back in afterwards. And just from a mental standpoint also, it's just so hard as well, physically and mentally.
Oh, absolutely, and we saw it firsthand. So we have not been in the fee for service for more than about, I guess, whatever, March of 2022. Prior to that, we spent about 4 years in, you could call it value-based care, right, or population health, but we were working with PT and AT groups that were on site directly with employers, and we're paid lump sum to manage the population. And so I remember, I remember I've about had a heart attack. So we get in, and people are using Sarah, and it's all going really well. And then we get some of the initial data back, and the group that we were working with, Pro Team Tactical, we're kind of both freaking out because we saw the number of incidents go up by like 30%. Like, oh no, like this is bad. Like this is so bad. They go talk to the fire chief, come back, and are just like all smiles. I'm like, what happened? Like, hey, people are getting like going to you for a shoulder strain. And we've already started to see over like I think we were working with them for like 9, 12 months at that point. Like, look, yes, our strains and sprains are going up, but our tears are falling off a cliff. So yeah, the fire chief was like, this is great. Like we're all gravy here. Like this is fantastic news. If you can tell me I have, instead of having 100 or 10 people out for 6 months, I have 100 people out for 6 weeks. Like even in that dramatic of a like an example, like still give me like the 100 out for 6 weeks. So yeah, that's having an in-house, whether it's, kind of like outsourced in-house or just fully in-house, that's Quad Med premise, and these others that are doing it. I think there's a lot of really good opportunity there. Well, I know we're starting to get into the time here, so I'm going to pivot to my final question, which is also my favorite.
Sure. Okay.
Daniel, if you had a magic wand and could fix one thing within PT, what would it be?
So I'm a big fan of like community healthcare. And so what I've seen like in the last 20-ish years, I'm only like 32, but but I remember is I'm seeing more and more consolidation. And that doesn't help anyone. That doesn't help doesn't help the patient. Some say it can because you have interoperability in healthcare and yada yada yada. But when you have more community providers that live in your community, that see your patients out there, and like they know that there's someone there that can help them, that they can walk into their office and see them. Like community providers are those small mom and pops. Where I am now, like I see, like we have therapists here that have been here for 30 years and 20 years, right? Like, that amazing value you provide, like that entire zip code, like they know like, oh, this place gets me better. And
Yep.
You have that rapport, and they know like they have so much trust in you because you've seen them. Like it's human nature. We are going to get hurt. And one of the things that makes a society, do you know the one thing that like makes a society? It was discovered by, I think, I forgot, archaeologists or anthropologists. It's a healed broken bone. All right. Like that's the foundation of a society. Is there someone there to take care of you when you're down and out? And we are those people. We can start creating that. We create the community and a place where people actually get better and they heal, right? And you need to be supported during that process because it doesn't happen overnight.
No.
We all know that. We live in a world where things do happen overnight. Thank you, Amazon. But our body is efficient only as well as we're healthy, and it takes as much time as it needs, and it needs to be stressed gradually, like returning to work gradually. And we need to become more resilient. And that happens when you have so many people care about you in your own community. And when you work for a bigger conglomerate where people are moving this and that, like I see this, like physical therapists are leaving jobs in less than a year now more than ever. Like it's just like go, go, go. Because the problem is it's not that they want to, they have to go to where the dollar it can stretch more, right? Like the expenses are so high and they're hitting that top end. And that's why they're leaving being clinical, even if they're good or not good, because the dollar can only go so high in this production, ecosystem that we have for fee for services and that, where they're not incentivized to stay clinical for 20 years, 30 years. You're not seeing that happen anymore. Not saying people should be, everyone should have their own journey, but the people that I spoke to that left to go into tech and stuff, they're like, I really miss this. I really miss having that relationship and getting people better and seeing that. Even though they're fulfilled now and they can see a ladder of director of sales or clinical liaison or account executive, coding, right? They miss interacting with people. That's why so many of us got into the field is you got to spend so much 30 minutes, 45 minutes, an hour with a person over the course of 13 weeks or 8 weeks or 10 weeks. Like you become their friend. It's like, and they have such, they're so grateful for your service, and you're so grateful that you are being part of that journey for them. And like I wish I could do that first in New York and Jersey, and then like across the country, because you know this as well as everyone. New York and Jersey, the reimbursement rate is probably the lowest in the country, right? It's New York, it's like the highest standard of living, right? And the lowest of the country. So if we can actually make it here, we can make it anywhere.
I agree with that, and I really like your point too on community. And then even those that leave the profession still keeping some sort of toe in the water, right? So I know our chief clinical officer, Paul, who I think you got to meet at PPS, he still treats a day or two a week. It just helps. It just helps, at least for his position. You could argue for sales, maybe not, but I don't know. I like if you're in it, you understand it. But anyway, I'm not here to opine on that. So anyway, Daniel, thank you so much. I'd like to wrap up with a couple of insights that I find throughout our conversation. And, I think a couple that I found is don't be afraid of letting your passion drive you to peeling back the onion and finding somewhere to go and play, right? And I think that you've shown how that can be very successful in a relatively short amount of time of just like letting that passion take you, owning it, and then just peeling back the onion and not taking no, but in a way like also not taking just like, well, because it is what it is, right? And not taking that as an answer. I think that's a very, very, very salient point. And I think that's what we're going to leave people with is let your passion take you, and don't take no or it is what it is as an answer. And you might find yourself in a similar position sooner than later. So where can people find you? What would you like to leave the audience with?
Yeah. So I'd also like to add one thing is you can't do it alone. All right. So I couldn't have done this much in 6 months if I didn't meet people, talk to them about these big ideas, and try to create a difference. I have a lot of other private practices that have championed like this cause. This is like their problem too, and they're willing to take their like ego out of it too. Like all of us are, we have our businesses and this and that, but willing to actually sacrifice time there, which as a business owner, no one has enough time. No. And dedicate at least an hour a week or 2 hours a week to like a cause like this is huge. And that's why I was able to do it in such short amount of time, 6 months, is because I'm working with so many other people. Everyone can find me on LinkedIn. That's where I guess I'm like the most active. I'm gonna probably try to go into more socials once my kids are a little bit older, but it's hard with 3 kids, man. If they want more information of like the currently active vehicle, they can go on ziacare.com, and They have a team there that is trying to champion this. So they're going to try to make this work. And PT and OT practices are they're like a backbone, but they're going to start trying to get more speech language pathologists. Dietitians are there and trying to expand out later. But it's all about the existing physical therapy and occupational therapists, because New York consolidation's happening at a fast rate. It's like these mom and pops are going down like every day. It seems like I'm seeing that generation of physical therapists. They can't sell it to the new generation because they have so much debt from school and everything. So their only exit strategy is taking an EBITDA from like USPH or one of these other groups that are just getting bigger and bigger and bigger. And those groups, you're not seeing those clinicians stay there for 20 years, unfortunately. So I'm hoping that I can stop that in its tracks so that next domino doesn't fall, because it won't be good for all of us. From my opinion, it won't be good for all of us.
No, I mean, I don't want to grow. I don't want to grow old in a world that doesn't have PT. No, just no. No.
Yeah.
So, I'm going to do my darndest to help prevent it and highlight stories like yours to help people realize hey, they can make a change too. And so with that, Daniel, I want to say thank you so much for your time, for your advice, for your story, and for your effort in helping create some more equality in payment, so that way we can turn this field that you and I both know and love from different sides of the equation, from just barely making it to for surviving to thriving. And so with that, they know where to find you. And thank you for listening to this episode of The Disruptors. Thank you for listening to another episode of The Disruptors. I hope that you were able to take one or two things away that you can apply immediately to your own innovation journey. As always, I'm your host, Stephen Cohen. This is sponsored by Sarah Health. Let's keep moving.